Thank you. I think what I'd like to do before we continue is to, for some of you at least, to give you some concepts on the differences between ablative CO2, non-ablative or coagulative CO2, and erbium, and why there are differences. When you showed the slide before, Chris, on erbium drilling in the skin, there's a few problems with that. Number one, all it's really doing is drilling. So you're producing a hole in the skin, and erbium really does not cause much thermal coagulation around it, as we know from previous studies on erbium and CO2 resurfacing. The importance of this is twofold. Number one, if you drill deeply in the skin with erbium, and if you resurface with erbium, anyone who's done it, you know that you get a lot of bleeding with erbium because it really does not coagulate anything. So drilling holes in the skin with erbium, at least to me, makes little or no sense, because if there's no heat involved, you most likely will not have any contraction, as Chris and Roy showed very beautifully. The second thing is I do believe that volumetric heating of the skin and causing a zone of thermal coagulation around the ablated area is important, because that, in fact, as Fitz showed many years ago, is really the key to wrinkle reduction and skin rejuvenation of CO2 resurfacing. And frankly, if you had no coagulative zones from that procedure, you really wouldn't get any skin remodeling, you wouldn't get any wrinkle reduction, and I think it's important to understand that CO2 and erbium are entirely different in terms of their effects on the skin. Now, my experience, I have to say, was very, very early on, I think right after you, Chris, and probably right along the time as you, Roy, and I got a prototype machine which was not very easy to use, and we treated 15 patients. We did it in a very short period of time. We treated patients without really understanding what would the pain issues be, what would the sedation issues be, what did we need to do for them. But what was interesting when we did the treatment was that we did notice the degree of skin contraction that all the other investigators within the study have shown. Now, we started this study in August 2006. We completed it in December. We treated 15 subjects, face and neck. Now, we gave one treatment per subject, and I was very interested in what Roy showed, in that when he did more treatments, he got quicker healing and, of course, better effects. We used 20 joules per millimeter, 20 millijoules at 400 to 1,000 microtreatment zones, and we did 2 passes, and basically we were doing 800 microtreatment zones per treatment. We had follow-up visits at 48 hours, 1 week, 1 month, 3 months of all the subjects. What we did notice is, again, as you saw before, we saw the swelling of the skin, erythema of the skin, and the punctate bleeding that, surprisingly enough to me, healed very, very rapidly. And at 3 or 4 days, patients were pretty much completely healed with no punctate bleeding and no edema, and sort of a mild erythema that lasted about 7 days. All of our patients were back in makeup approximately anywhere between 3 and 5 days, which was found by other investigators. We did give prophylactic Valtrex before treatment. We did use a topical anesthetic that was used. We used benzocaine, tetracaine, lidocaine for approximately an hour before. Some of our patients were given Valium. Some of our patients were not given Valium. None of them were given any opioids or Percocet or Tylenol number 3 for pain. And we did not do any vinegar soaks, although they were instructed to do so. I don't know the role of vinegar. Maybe some of the investigators know, but we did use Aquaphor healing ointment post-treatment and had no significant complications in any of our patients in terms of infection, either with bacteria or herpes, or any significant problems with pigmentation or scarring. Subjects were evaluated for changes in appearance of wrinkles, texture, and pigmentation using a standardized quartile improvement. And if you look at this chart here, it's a bit busy, but you can see that erythema at 72 hours was seen in 100% of subjects, and dropping down to 1 month postoperatively in 4% or 27%. And this erythema was not the erythema that one sees with CO2. It was a very mild sunburn type erythema seen in a small percentage of patients and easily covered with makeup. At 3 months, no one had any erythema left, as you would expect. Edema was present in almost all of our patients at 72 hours, dropping down to about 1 week, still seeing some edema, and at 1 month it was gone. Post-inflammatory hyperpigmentation, we did see 2 patients at 1 month with mild post-inflammatory hyperpigmentation. However, their sun exposure history was questionable, with 2 of them traveling down south and then coming home with a little pigmentation. We saw no hypopigmentation, we saw no evidence of infection, and we saw no evidence of any scarring or persistent hypopigmentation. Now, this is a slide, and on face it's not very impressive, but if you look here after 1 treatment, you can see at post 1 treatment, 20 millijoules, 800 MTZs, really remarkable change in this patient's complexion and his degree of pigmentation. Now, it's not going to set the world on fire, and as Roy pointed out and Chris pointed out, we're very early into treatment using this modality and really have not fully explored its potential. This is another patient here, and I was not impressed seeing the patients post-operatively in many instances, but we looked back and looked at our Omnia pictures, and indeed we did see improvements in pigmentation and improvements in fine wrinkling. And I think as we explore this modality further, doing more aggressive treatment as Roy is doing now, and doing retreatments, which with the short downtime patients will probably agree to do, I think we will improve this technique tremendously. And this is another slide. It's not readily shown here, showing some improvement of periocular wrinkles in this individual, and also, although the color of the slides is off, there was improvement in pigmentation around the eyes. Now, in summary, what I think is that fractional CO2 resurfacing is something that is new, something that is very exciting, it's something that is different. And I think as you follow this along, as we continue our clinical trials, we will see further improvements in the technique and be able to give you further information with regard to its safety and its efficacy. Thank you.